Good afternoon, everyone, and welcome to this meeting of the Health and Wellbeing Board on, what is the date? The 9th of March, 10th of March, forgive me, thank you. This is our first public meeting in some time, so welcome to everyone that's here. I am Councillor Polly Newstub and Chair of the Health and Wellbeing Board. If I could have apologies from absence, I've got apologies from VJ Taylor and Councillor Blacker. Any other apologies to be recorded, Neha? Chris Hilton, yeah, Chris Hilton has, I think, sending a substitute. Lizzie, she's not here. Okay, lovely, thank you. And I think we've got, do we have you here, Mark, in lieu of anyone else? No, you're here in your own right.
No, I'm here for Simon Crawford, actually.
Yes, that's what I was
the
thinking.
representative, yeah, for London
Lovely.
North West.
Brilliant, thank you, Mark. Urgent matters, anything arising that anyone wants to raise here? Nope. Okay, thank you. Declarations of interest? None online. I'm trying to channel being able to look online as well as in the room. Matters to be considered in private. I don't believe there are any. And minutes of the last public meeting that we held, which was on Thursday, 26th of June. They are included in the agenda pack that everyone has had. If anyone has any comments or additions or changes they'd like to make, please make them now. No, everyone's happy, but we can sign that off as a declaration of the record. Which takes us on to our first key point for discussion, which is the HDRC Year 2 update, which is from Gabby. Is that right? Not Gabby, Vaish, forgive me. Vaish, over to you.
Hello, can you hear me? So I'm just going to give you an update. I think we said we'll give an annual update to the Health and Wellbeing Board about progress of our health determinants research collaboration, which we've renamed Evidence and Learning for Health in response to some feedback around kind of a more kind of engaging name that's less long. So this is a Year 2 progress update. So just to recap for colleagues who aren't aware of the programme, so we're funded by the National Institute of Health Research to build research capacity in local government around health determinants, so our building blocks of health. We went live in January 24, so we're just 2 years, 2 months into the programme. The first 2 years have been really foundational, and we've intentionally kind of set up the programme to be kind of long-lasting, building stable foundations. So in years 1 and 2, we've, well, in the first year, we've done a lot to establish the governance, performance and financial frameworks, and we've initiated work stream rhythms. There was a piece of work in year 1 to better understand the current culture of evidence use in the council, and we've done a lot to build the relationships of the collaboration. So I should say that we're a partnership between 3 universities, Imperial, London School of Hygiene and Tropical Medicine, and the Institute of Development Studies, and 3 community sector partners, EHCVS, Complete Here Today, Southall Community Alliance and GOSAD. As well as Ealing Council. So a lot of work to kind of build and foster the collaboration, relationship and shared goals, and aligning agendas so that work's mutually beneficial for all. This year, year 2, we've done a lot to build the HDRC team. So we've recruited several new members of staff, research capacity lead, comms lead, which is joint with our team and another team, participatory research specialist, evaluation specialist, and a research data scientist. We've done a lot since our comms lead started to really socialise the programme's purpose and progress, and we've developed new comms assets, including a website. So kind of encourage colleagues to have a look at the website for more information. In terms of some of our key areas, So what makes, I think, our HGRC different from the other HGRCs? I think all are doing quite similar things, all have a strand around community research. We're really proud of our work to build community research capacity. So we're working with the Institute of Development Studies in a method called participatory action research. So since January that launched, and we have our 22 community researchers representing our diverse communities in Ealing, trained to gather stories from their communities, which they did between January and sort of June of last year. These were rich narratives around people's lives. We gave them some training around health determinants and building blocks of health, so that they weren't asking questions about health in inverted commas, where people might just focus on health services, but it was about their lives, and they analysed pathways towards good and poor health into a big systems map. I think I have a picture here you could see on the top right. So people were looking at factors that contributed to good and poor health. The community research, we had a big showcase in this room in June, and a lot of council leadership were there, and it really showed how powerful the community researchers were in terms of driving the process and leading the change. These community researchers have chosen 6 action research groups based on like predominant themes in those systems maps, and also areas of kind of real interest and drive for the community researchers. So these are on green spaces, and it's links to positive wellbeing, lack of youth spaces and activities and how that might lead to antisocial behaviour, the links between temporary accommodation and poor health, particularly mental health, links between domestic violence and drugs and alcohol use, and language barriers and barriers to employment as a result of that. So they formed these action research groups. They've started to think through problems and solution trees. And from January, we've invited council staff and voluntary sector staff to start to co-create further actions with the action research groups. Just before I move on, some reflections of the process. If you think about the ladder of participation, we're kind of operating in much more community agency sides of the spectrum. And it's really interesting learning as we're kind of now meeting with the system, whether it's the council or other partners, of how there needs to be work to kind of marry that gap a bit. So there's just lots of learning from the project, and we have an developmental evaluation happening alongside the project. So we're getting a lot of real-time learning from the initiative, and that's something we want to feed back to the council's connected communities work, because this is really showing us some learning of how we might do this and some of the barriers to doing this well. Another kind of key component of the HGRC is to think about data linkage and making data more visible and accessible. So one pilot project is in the children's space. So we're working with Imperial College, linking children's social care and education data into North West London's NHS data, WISIC. So we're at the point where I think it's started to flow. So we've signed off all the authorization and the agreements. And so the next stage over the next few months will be to build kind of use case examples, one of which is that kind of strategic outcomes framework for us Children and Young People's Board, but also to think with partners and colleagues around more use cases for this work, things like school health profiles and other things that we might be able to do as a result of it. Just to say, evaluation is a key component from the HGRC, not only capacity building of staff, but also embedding evaluation of our programme. So we're like learning as we go along. So we're working with the London School of Hygiene and Tropical Medicine on that. Not going to go into detail. The final thing, kind of core thing to mention, is our training and capacity building offer. I'm not going to go into details of the slides, you've got this in your pack, but just to say that we want to build the capacity of council staff as well as voluntary sector staff. And our training and delivery plan was co-developed between the academic community and council staff. They wanted the offer to be equally available both for council staff and the voluntary sector, so that's one of our principles. We have now online assets on our website, a community of practice, and opportunities for staff to bring practice-based work to the team. We're also working more intensively with certain teams, so they're early demonstrator kind of teams. So that's in the climate team, with the I'm trying to remember, the children's and young people's team, and also with housing in terms of the early adopting teams. Also, just to say that we've got some academic placements. So one researcher for LSHTM is with us for 4 months, investigating the issue of households with multiple occupancies with the regulatory team, and discovering some really interesting findings about HMOs. Another academic placement will start in a few weeks, looking at the opportunities of the health-related behaviour survey, which is a survey that's conducted every 2 years on our school-age children population, and harnessing the kind of opportunities around that data set and data linkage around that. So in terms of what's gone well, and I'm going to bring Anna and Gurpreet also for their reflections because they're part of the work. I think we've been very intentional in building these strong foundations and really tried to spend time as a collaboration with away days and other sort of processes to build that sense of collaboration. I think that kind of EDI element, not only with our partners being embedded in the governance and the work streams, but also especially that community researcher element, which I'm really excited about where it's going to go, but there's such potential with that cohort of community researchers. In terms of the challenges, I guess until recently when we've had our comms lead, I think we've had a bit of a challenge to communicate the vision and purpose of such a big and complex project. And the concept of research meaning different things to different people can feel quite academic, and for local government that doesn't have a culture, unlike the NHS in research, it's quite a new kind of concept. And then I guess the second one will be very familiar to most of you about staff capacity to engage. Staff are extremely stretched, there's lots of transformation and work happening. So I think we've tried to pitch it as, how can we help you meet your priorities and the work that you need to do, and how do we embed kind of more rigorous research and evaluation as part of that. And there's an argument, I guess, in a time of constraint, research has even more value because we have even limited resources and we need to make sure that what we're doing is making an impact. So yes, plans for year 3. I think we're really thinking carefully with the IDS colleagues and our community researchers and internal council colleagues, including those involved in the Connect to Communities work. What is the future for this cohort of community researchers, and how that supports some of the council's ambitions. We want to deepen our work with some of our directorates and teams and our communities of practice. As I mentioned, the CYP data dashboards, sort of scoping out some use case examples, and then trying to get more, becoming a more active research collaboration. So we are developing a research priority setting matrix based on council plan, national priorities, local research gaps. And we are also doing a set of policies around a research governance framework, so the ethics, data governance, community public involvement standards for research. So we want to be successful in applying for further research funding, and we've got in, we're applying for some grants this year. So let's see where we get to with that. And then also we want to keep, with our developmental evaluation approach, starting to share impact stories of the benefit of the HDRC, particularly to our funders. We're uncertain of what will happen after year 5. So that's continue to kind of share learning as well as the emerging impacts of the work. But I'd also encourage you all to look at the website, and please do get in touch if you have any further questions.
Thank you so much, Vaish. I would say it's been really fantastic to see the whole project coming to life, I suppose, and that was most evident with the showcase that the community action researchers shared with us, which was great. And it is really useful for us to be able to think very realistically and practically about those wider determinants in a way that very much has resident voice at its centre. I'd also point everyone to the work around capacity building in the BCS and for staff, actually equally important. And thank you for making that point. Equipping ourselves and our voluntary sector and others to use data effectively and to root it in what we know about our residents and what they want from us and need from us, rather than what we think they want and need, is sounds obvious, but is hard to do, and the quality of the materials there are really high. So thank you very much. I very much look forward to year 3 and what happens to that, and to developing that common language around how we talk and work with empathy in a practical way that is solutions orientated. So thank you for that. Does anyone have any questions for Vaish? Kerry?
Thank you, Chair. Thank you, Vaish. Really helpful report, really interesting, and obviously a huge amount of work's gone into this. The area that I'm interested in going forward is, how do we evidence and track where the HDRC is impacting the work of the council and partners going forward, especially within the integrator function? And how do we show that we're not just researching, but we're being research-led in terms of the decision-making and the actions that we're taking as a health and social care system in the Borough of Ealing? Yeah. That's a key bit, I think.
Thank you. I think there's a lot that we could be doing going forward around the neighbourhood health piece and the integrated function. I think Rosie and my team has been to some of the meetings around how to embed particularly like evaluation in some of the kind of neighbourhood projects going forward. But yeah, that's definitely something kind of we could have a further think about. Thanks. And
you've got a follow-up question, Karen? Off you go.
Thank you, Chair. I think it's really important. Sorry, I think it's really important for the Health and Wellbeing Board and its function and role of overseeing and supporting the strategic direction of the integrator and of the Ealing Health and Social Care system to be using this and to be understanding how we're changing outcomes for local people as a result of the work of the HDRC, as well as other areas of process, and having a more structured approach to how we do that here, I think is going to be key.
Agreed. Thank you, Kerry, for that. Neha?
I would totally agree with what you're saying, Kerry. I think there is also something about all of the research opportunities and work that is happening within Ealing, and how we map all of that, understand where there is any overlap or not, and where there are opportunities that actually where research could really help us as we develop the next stage with integrators and neighbourhood teams, because there are lots of community champion type roles, link worker roles, and things like that. And are we maximising this expertise in that space? I'd love to think that through.
Thanks, Neha. Yeah, no, I agree. Needs some thought. And I guess kind of roles like the community researchers, I mean, it may not be just this pool, but other people who can be involved in shaping research for their local area. I don't know, want to bring, Gurpreet.
Research priorities have been shaped by the voluntary sector and local residents in terms of like community researchers, so it's taking place, and we're also developing an external fundraising strategy to make sure that we can kind of bring in more external funding based on the research gathered by our community researchers.
Great, thank you everyone for that. I think it's I think it's a really, really solid foundation, but we need to keep that up and make sure we're still very much bringing it to life within the organisation and within the community. Anna, do you want to give us some closing notes?
Yeah, thanks, Chair. Thanks, Vice, for taking us through that. It's great. I think it's just also reflecting, and this isn't just my view, this is from lots of the feedback from partners and things. It feels like it's really helped us kick forward and shift a lot of the local relationships as well. It feels like equal voices around the table with the organisations. There's local BCS and academic organisations on the board as well, so different ones, which is great, giving the time to this, and obviously the community researchers. So it feels like it's really driving and shifting a lot of the health and wellbeing strategy vision forward as well, and gives us so many opportunities. I'm just thinking that data linkage with children's and you know, it's things we've been talking about for about 30 years, and it's great. Just it's given us that little bit of kind of like leeway, money, teams, expertise in the team as well, which we haven't had before, and I think it's really great. And I think that thing about impact, Kerry, I think that's where we start seeing that coming through, is what does that mean in 2 years' time, and really thinking about that. Thank you.
Great. And so, yes, absolutely, we've agreed for an annual update. I think obviously we want to know about what we're doing here, but learning about what other similar projects are doing elsewhere would be really helpful, I think, too. I don't know how we incorporate that, but you know, it is a new shift, and it would be great to see how it's impacting elsewhere as well. Thank you very much. Moving on to the next item, which I believe is our Health Watch report into the transition that we went through when we moved our telecare services. Okay. But just for the benefit of everyone in the room and online, the streaming has just stopped, so we're just going to try and fix that before we go again. Just while we're waiting for the streaming to come online, Roy, I'm aware that you've got a question about Careline in the questions from members of the public. I'm going to propose that you bring that question into the main body of the agenda and respond to David's presentation, unless you have any objections.
Apologies, I'm a last minute stand-in for Chris.
Hi, Roy. Did you we can't hear you. It might be something to do with the streaming. We can't hear you. But Mark, would you mind speaking? See if it's
Yeah, sure. I can't hear Roy either.
right. So we can hear Mark online, but we can't hear you, Roy. So I think that means it's something at your end. And are we back online? Not yet. Okay, we've got IT coming to get us back online. Hi, Roy. Just once we're back online, we're going to take the report from David at Health Watch on their findings into Careline. I was going to take your question that you've given us for as a question from a member of the public following that presentation, if that's okay with you. So if we're not able to hear you by then, I'll read out your question. Okay. Brilliant. We're told that the streaming is fine. Thank you very much for your support there. Apologies for the delay, but it was very timely as it was between two agenda items. So if I could pass over to David Crawley, who is a project officer at Healthwatch Ealing, and congratulate him on the birth of his daughter recently as well.
Thank you.
He will, you've got the report within the pack, but he will give us an overview of the findings of the report. I'm going to preface it by saying that we transitioned over to Careline Harrow, I don't even know how long ago it was, 2.5 years ago, possibly. And we have given this whole area a significant amount of scrutiny in our various meetings, obviously internally in terms of operational management, and senior visits and reporting from the service, as well as here and as well as at HASP. It was always the commitment that we would ask our partners at Healthwatch to deliver a specific report. They are there to hold us to account, but I'm hoping that that this is something we can put behind us. Having prefaced it like that, I will leave it over to you, David, to give us the meat of the report and your findings. Thank you.
Thank you, Councillor. First, let me give a quick update verbally on the status of Healthwatch, because I'm sure that's something everyone is wondering. The last we heard from the Department of Health and Social Services was that the statutory functions of Healthwatch, social care wise, will be allocated to the local authority, and healthcare wise to the ICB. We don't have a clear timeline on when that is going to occur. We know that Healthwatch Ealing as an entity will exist for at least another year, and I will update further when I have more information. Now, to the report itself, we spoke with 22 service users of Careline in Ealing and 4 members of staff, just to go through some findings. 19 people out of 22 told us that they felt that Careline made them feel safe and independent. No one told us it didn't. The only other response was they didn't prefer to say, and that's because it was a carer answering on behalf of someone that did use the service. Respondents that we spoke with had a wide range of how long they use Careline for. Most of them had been for more than 4 years, and the rest were more recent, 3 years and lower. In terms of how useful they found the actual service, when we spoke to respondents that had an incident, they said that it was a very useful service. One person in particular told us that they felt alone, scared. They had eyesight issues, they couldn't see. Careline contacted them, helped them, and made them feel safe. When individuals had to contact Careline in a non-emergency situation, most told us that when they had to, they were through to a person within a few minutes. Only one person told us that it took a while for them to get through on the phone. The most common piece of equipment people used was a pendant or a fall alarm. Some did have pull alarms installed in their home. Now, in terms of the actual transition between the Ealing and Harrow services, when we asked if individuals had any issues with the transition, most told us no. Only one respondent out of the 22 service users we were able to contact told us that they had issues with the transition. That was due to equipment collection and payment issues with miscommunications between the councils. Most did not notice any change in service, with one person telling us that they felt the service had improved. We did hear concerns regarding the timeline and communication of the transition. Some told us that they did not know that there was a transition at all until it had already occurred, while others said while they didn't have any issue with the transition, they wish it had been communicated to them more. In terms of what staff told us about what it's like to work for Careline, people told us they had very good job satisfaction. They know that they work in a high, fast-paced environment, but they felt very good about the work that they do. Employees told us that they felt supported by their team leader, their management. And one thing that we did find to be a slight concern was, while we know through communications of Harrow Council that there are employee support programs that are offered, the employees that we spoke with were not aware of them. Like, they knew they existed, but they didn't know how to access them or what they entailed. What management of Careline told us, some key themes: the digital to analog switchover. Harrow Careline was the first in London to do it, beginning in 2019 and continuing through the pandemic, and this allowed them for the switchover in Ealing to be prepared. There's no charge currently for the equipment for any service user, as any equipment less than £1,000 is paid for by the local authority under the Care Act. Ealing Council does not intend to charge service users for any call-outs nor monitoring, and any changes that would occur is subject to service user consultation. The management told us that they do outreach to service users, birthday calls, annual surveys based on a sample size of the populace, and they do an 8-week post-installation follow-up call. Some recommendations that we made include communicating clearly with the residents of Ealing. We understand and acknowledge circumstances over this handover were not usual business for the council, but we do recommend that communication is made clearly with residents and service users about changes. Share information through at least 2 communication channels: posted letter, SMS message, phone call. Service user engagement so far that we've seen from the Careline service has been good, but we would always like to see more. We also recommend staff well-being be put at the forefront of our minds. This is a very taxing job, being an emergency service, and we just know that good staff mental well-being leads to less turnover in staff, which leads to a better service. And we also recommend promoting the Careline service to raise the awareness of it. While we did collect 22 responses from service users, we went out into the community and we talked to more people than 22. It was only 22 actually used the service. Most people we spoke with at events where we were likely to find service users of Careline, like events regard force prevention week, things like that. Most didn't know that the service existed. I touched on that, and that is our report on our findings in total. We were happy with what we saw. No major concerns from what we saw through our communications with the council and the service users we were able to contact. Thank you.
David, thank you very much. If okay with you, I'll come back to the issue of Health Watch after our discussion around Careline. And I would just like to say, firstly, thank you very much for that work. It is a thorough piece of work, and I appreciate that due to the nature of the work itself, it is relatively difficult to find those users to speak to, given GDPR issues and so on. We can't obviously comment on the staffing of the service, although we commend your recommendations and that your acknowledgement of the nature of the work. And I'm sure Harrow Careline will take on those elements. I think that you were happy with what you saw, and that we have a broader understanding that there have been significant benefits, particularly around digital switchover and quality of that provision, speed of response and so on, makes me feel very comfortable. Kerry, I think you have a contribution or a question, and then I will read out Roy's question unless he's able to contribute himself. One moment.
Thank you, Chair, and thank you, David. And just to reiterate your points, Chair, in terms of the importance of the work with Health Watch to hold us to account and to bring an independent view on services that are provided, I think is highly important. And I think later discussions with regard to the future of Health Watch is really key in terms of how we work as a system. Just to recall some of the drivers for the change from Ealing provided to a Harrow provision of Careline, which took place on the 1st of the 4th, 2024, so some time ago. This was as a result of some significant safeguarding concerns within the service that was provided by the council. The fact that the service, as then wasn't it's not registered, but it's logged with a national organisation, and the council provided service hadn't hit the standards that were required to achieve to get that level of registration. I think the opportunities that are being developed with the Harrow provider and partner around the digital opportunities, as David and you have described, Chair, are absolutely key in terms of our wider preventative agenda and how we work with local government and NHS partners in this space. So I think that's really important, and we're very well placed to develop that opportunity going forward. I think also the fact that David's been able to, and colleagues at Carewatch have been able to access data about the services is something that was unseen before. We had no information about performance levels and activities. So the performance comes from a baseline from when we started with Harrow rather than comparable to a previous baseline because there wasn't data. And the last point, and it is an interesting one, and I think we can always do more to communicate with local people and explain what's happening, but the fact that local people didn't notice the transfer had occurred, I think suggests that there was a strong and a lot of focused work to support the transfer. I'm not saying that we shouldn't have communicated more, because obviously we should, but I think that reflects in terms of people's experience of the transfer. And I think we can take some of the recommendations back, David, in terms of the support for staff and through our contractual arrangements with Harrow and feed that into the discussions with them. So thank you very much.
Thank you.
Do you want to respond, or?
No, I just want to thank Kerry for those points.
Right, Roy, are you audible yet, or shall I read out your question? Have you given me a thumbs up? Yep. Okay, here we go. This is Roy's question verbatim. We welcome many of the recommendations in this report on Careline. However, on the basis of some subscribers, parenthesis, lack of information, short timescales, etc., close parenthesis, we strongly dispute the finding that the transition from Ealing Careline to Harrow Careline raised very few operational issues. We understand that this finding was based on a very small number of subscribers contacted, 22 out of 2,000. If lessons are to be learned from it is important that Health Watch reports includes a representative number of individuals who received the service. Can this be clarified? So, David, it would be good to get we've talked about research earlier today, but about your methodology and statistical relevance, and I suppose the difference between quant and qual in terms of research and how you pass that into formulating your findings.
So we, in terms of this particular study, we wanted, because the background that we heard was so contentious, we wanted to go into this as independently as possible. So we decided to have conversations with carers, have conversations with stakeholders to form our survey. Then we went to different events throughout the borough, in Southall, in Hanwell, etc., in Ealing proper. Then that would be relevant to people who had experience with Careline. We spoke to close to 100 individuals, and unfortunately only 22 of them were service users or cared for a service user. We acknowledge that this is a small number, but when you look at the grand scheme of the borough as a whole, 2,000 out of the hundreds of thousands that live in Ealing, it is a difficult population to reach. And we at Health Watch Ealing are also a small team. If we had more resources, we might have been able to go to more events that are occurring at the same time. But unfortunately, we live within our means and within our limitations. I will say, though, I am proud of the numbers we got because of the limitations that we did have in concerns to GDPR and such. And these were important conversations, and we made those individuals feel heard, which is the whole point of Health Watch, is to give an independent voice to the service user. So thank you, Rob, for your question.
It's great. Thank you very much, David. Yeah, I would draw people's attention to Kerry's comment on safeguarding concerns with the previous service, and people can draw whatever conclusions they like, but it was an essential move, and we'll take certainly on board your recommendations around communications at the point of transition. But I am confident that we have something that keeps people happy and safe, and more importantly, feeling happy and safe in the borough. Robert, you've got some.
Thank you, Councillor. David, I think it's an excellent report. It gives us some really helpful insights. I just wanted to express a few thoughts on recommendation related to awareness of Careline as a service, and I suppose I just was thinking about what the findings were in terms of where the service is being mostly used at the present time, and there may be some towns in the borough where there may be less awareness, and you know, whether there's anything in your mind in terms of how we might take that awareness campaign forward, think about marketing, and you know how we might take that forward, and any thoughts that you might have in the space related to young carers. So young carers, we obviously provide support here in Ealing for young carers, and I'm just wondering about the links between how we might be able to develop the links between young carers and some of the awareness of the Careline service that might in turn actually support young carers as well. So those are just a couple of thoughts.
I'm going to jump in, David, before you respond. Firstly, there's a really excellent point and connection. Thank you very much, Robert. I would love to hear David's thoughts on that, and certainly we can take that away. Careline, Harrow Careline is available within Ealing to Care Act eligible residents. It's not, I don't believe, available commercially to Ealing residents. So there is an issue. If we're raising awareness, it should be with our social workers and with those who are making those recommendations and care packages, and that's certainly, I'm sure, something Kerry can take away. But I just wanted to make that distinction. There are many commercial telecare providers out there. Harrow Careline is not one that's currently available to Ealing residents. But really, thank you for your comment on young carers. It's a really important dimension. Over to you, David.
Thank you, Council, and thank you, Robert, for your questions. I reiterate what Councillor Newstup says in terms of young carers, although if they do care for someone who is eligible, definitely want to get them linked up with a Careline service. Out of all of our respondents, we got the least from Hanwell. We didn't get anyone that lived in Perivale and Southall. So having a targeted approach to those areas of the borough would be very good, especially Southall, because I don't know if I saw any material for Careline that was translated into community languages during the course of this. I might have, and I don't recall at this moment. But whatever we can do to reach all corners of the borough is something I am wholeheartedly behind. Thank you.
Thank you, David. And just to say, no, I appreciate those comments about the statutory element to this work, but I'm really happy to be contacted if we can be of any help in children's services, particularly with that awareness raising for young carers, and indeed with some of our early intervention and early help work more generally in some of these pockets in the borough where there may be low take up. We can make sure that there is information available in locations that we're working from as a children's services as well.
Great, and if I could leave that to perhaps Kerry and Robert to convene on, and I suppose interesting if we had no respondents that David was able to find to speak to. I don't know how that correlates to the number of residents we have using the service in each of those areas. It would perhaps be interesting. So, Kerry, if I could ask you to look into that and to make sure our social workers are mindful of the service and recommending it where it could be useful, and also that we're joining the social worker teams up with thinking about how it could be a service that could support young carers who obviously have unique and specialist care challenges around concerns when they can't be with the person they're caring for. Kerry, one last comment.
Thank you, Chair. And just to add that Careline and use of equipment is part of our transformation plan within adult social care, and I'll make sure that Robert's team are engaged with that process. And it's a really good point, I hadn't caught that.
Yeah, and equally, there's a huge amount of work being undertaken around the use of technology in this space, and I think there's some really interesting things out there that could be augment the traditional telecare type of service. Right, should we have a brief foray into Health Watch and Patient Voice? Thank you very much, David, for that update. We certainly really value, and we've been very vocal about valuing your input, your research, your support, but most importantly, I suppose keeping our feet to the flame and that independent voice within the system and within the health network. It seems surprising to me that those statutory functions should be moving into social care and to the ICB. It very much feels like marking our own homework, and I think, if anything, with the current changes that are happening, it is more important than ever that we have both independent scrutiny that comes early and supportively rather than late and in crisis, and that we are including patient voice within the work that we do in a constructive and statutory way. So I'm sure other people will have comments, but very glad to know that you're still with us as hopefully you personally, but also as an organisation for a year. And I suppose those conversations will evolve over the coming months. And we need to be very clear that we, as a system, think about patient voice and independent scrutiny of us as a collective system, as we are all expected to work ever more closely together. It feels more important than ever that we have that independent perspective at the table. I think I'll leave it there. Does anyone else have anything they want to add to that? Kerry?
I think, again, this links to how we work as a Health and Wellbeing Board and the integrator function, and the opportunities around working with Health Watch or a successor organisation in terms of our community engagement. The partnership boards are led within Adult Social Care and the Council within my department, and it always seems a bit like your point earlier, Chair, in terms of holding us to account, that I'm managing the engagement with people to engage about how my services are working or otherwise doesn't seem right. And I think there is a real opportunity for us as a borough-based partnership to review how we do in engagement and look to an independent partner to support us within that space. I think there's lots of engagement going on in lots of spaces, lots of duplication, and there's an opportunity to get an independent partner to lead on that for us.
Yeah, and I completely agree. And I think we can evolve those conversations in the coming months, as I said. And a lot of those things don't just sit within the health space, frankly. I mean, they are a system-wide issue that we need to be cognizant of. Right. Does anyone else have any comments either on Health Watch or on the Careline report? In which case I'll say thank you very much, David, for your input. We have a Better Care Fund verbal update. I'm not sure who is giving us the verbal update. Is that you, Kerry? Over to you.
So thank you. This should be fairly quick, that the guidance has been issued and we've got a deadline of sign off for May. Nahar and colleagues and Adenike on our side and Avatar are working very closely to progress the BCF to be signed off. Broadly, we think it's going to be a similar position as the previous year with the financial rollover, but with much stronger signals in terms of moving towards a neighbourhood health model and some expectations in terms of us setting out our neighbourhood strategies. I think the ask is, Chair, that we would look to bring it to Health and Wellbeing Board for May, but because of the elections, we think that's going to be problematic. So really just to say here, we'll probably be asking you for sign off outside of the public sphere because of the election process, and we can't do that in public if that's agreeable with you.
Yep, certainly. I mean, just for the benefits of those that aren't quite as involved in the process, the Better Care Fund is where we pool finances to do things that are better done together, and is an important part of the work that we do, and is only one of the levers that we hope to be able to deploy in terms of working more effectively together for the benefit of our residents. Fine. I mean, I would obviously prefer more detail about what work that will be funding. I assume we'll continue with elements of reablement and discharge support to support our acutes within the system, but I'm sure that detail will follow. Again, with all of these things, I would very much prefer that we don't only focus on the financials, but focus on what the benefits of that work is for our residents, so that we can, I suppose, understand and celebrate the benefits of working more effectively and more closely together. So thank you for that. I'm going to move on to questions. Does anyone else have any comment on that, by the way? Sorry. I'm going to move on to questions from members of the public. We have one more from Roy, and we have a number from, forgive me, Dr. Elizabeth Jones, who's online. Elizabeth, we're very informal here, so forgive me I hope you don't mind me calling you by your first name. I'm going to go to Roy Willis in his capacity as ERSCAG representative, and he has a second question, and then I'll come to you if that's okay, Elizabeth, because all your questions are around the same issue. And Roy, so I'll read out your question again. Yep. Okay, so Roy, for whatever reason, is let me just find Roy's question. Roy's question is around the London living wage. So one of the things that certainly I'm most proud of as an administration that we've been able to do the last 4 years is commit to paying our carers within Ealing, where we're commissioning that work, the London living wage, was a significant investment on our part. Obviously, we would hope that all carers were paid the London living wage, but we can really only influence and fund those that we are commissioning ourselves. Roy's question is, Ealing has been encouraging local employers to be compliant with the Living Wage Foundation by paying employees at least £14.80 per hour. It is very disappointing to find that Minster Care, who has large scale contracts from Ealing for residential care in 4 Ealing care homes, does not pay the London living wage to its residential care staff. Can Ealing urgently use its contractual and financial powers to ensure Minster Care pays London living wage to these key workers? And could you let me, that's the end of that. And it's also worth noting that we have Councillor Cam Nagpal here, who is one of our great champions of the London living wage. So good to see you here. Kerry, I think you're probably best placed in terms of our general role in influencing and managing the market within Ealing. Do you want to pick that up?
Thank you very much, Chair, and thank you very much for your question, Roy. As you say, we think that the application of the London living wage has made a significant difference to some of the lowest paid workers in the health and social care sector in Ealing. We know that the council's decision to fund the London living wage for people in the community and working in care has raised over 2,500 people the income that they can earn, and we think that makes significant differences into terms of the stability of the market in Ealing, but also in terms of public health. These are almost all women working in this sector, and then a very diverse workforce as well in this space. So it is something that we're very proud of from a service perspective. Also, we were very disappointed to learn that Minster Care, as part of the PFI, were no longer paying the real living wage to some of their staff at the PFI care homes. We've raised this formally with them. They're not contractually required to pay the London living wage to their staff. We, as a council, we're taking the decision that would only be for providers in the community, but it's something we've asked them to look at. Obviously, there'd be a significant financial impact on the council if they were to go back to paying London living wage to all their staff within the contract, but it's something that we're looking at. And if they are to move into paying all their staff the London living wage, that will be an impact on our MTFS position for the coming year. But just to be clear, Chair, they only stopped paying the London living wage in this current financial year. So the previous years they had been paying the London living wage, but we were very disappointed to see that they hadn't upped the money again for the financial year 25-26.
Thank you. And I mean, this very much illustrates the stress and the tensions within this area. Welcome Baroness Casey's work and focus and attention on some of this, and there are moves towards a national pay deal for carers. Again, we welcome that within the context of understanding that will increase pressures on the amount of money we will need to spend on care, and that is probably a good thing, but we're going to have to find the money from somewhere. I'd love to bring in Councillor Nagpal, who had your hand up.
Thank you, Chair, and thank you for being so generous with your comments earlier. As you said, I am championing the London living wage in Ealing as Cabinet Member for Decent Living Incomes. And I'd just like to add to what Kerry said. You know, we are seeing that there are organisations who are not continuing their accreditation because they are finding it a challenge. But then there are many organisations who are choosing to accredit now for the first time because of all of the awareness that we are bringing to the benefits of paying the London living wage, Chair. And, you know, we've seen with so many organisations who may have initially hesitated, given it is a huge outlay, but they are rewarded with motivated staff who really feel valued, and that goes a long way, I think, certainly in this space, and also is great for reputation. So I just wanted to add those comments to what Kerry said, because it is something we're seeing, but you know, we are also seeing on the other side that it's really valued by organisations that work with organisations who pay the London living wage, and is great for reputation as well as the staff who feel very valued. Thank you.
It's lovely, thank you. Right, thank you for that. I mean, Kerry, if you could, I mean, obviously we're moving into the pay negotiations time of year around our relationships with our providers within the borough, and if they could be pushing very hard on that, that would be great. But obviously we have a financial envelope that we have to operate within. Kerry has another comment.
Just to comment on Councillor Nagfel's point in terms of staffing and what it means for recruitment and retention in the sector. And obviously the care sector is a very challenging space at the moment and expected to get more challenging in the future. We think that payment of the London Living Wage within the care sector in Ealing has helped us drive forward in terms of low unit costs. So we've got bottom quartile cost for domiciliary care in London, but high quality outcomes. We've got top quartile in terms of CQC rated providers. So we're low cost, high quality in Ealing. And I think a lot of that is driven not only by our great colleagues working in the market management sector, but the fact that we're paying London Living Wage to staff in this space.
Thank you, Kerry. And it would be useful for the board to get an update really on the vacancies and the projected gaps within our care system within Ealing, particularly as we know that further visa restrictions are going to be implemented, and if that has an impact. I know we've looked before at the number of people we have working on care visas, and we should be mindful of what, if any, impact we expect that to have on the sector. If I could ask you to take that away, that would be great. Right, we have questions from, forgive me, I'm just going to flip over, from Dr. Elizabeth Jones, who is a South Acton resident. Dr. Jones, are you happy to ask your questions to the board, or want me to summarise, or what would you prefer? You can say it. Right, lovely. I think you're on mute, but the chair is yours. I think you're still on mute. I think it's something you need to do it. I don't think we have muted you. Take your time, don't worry.
I think I'm unmuted now. Is that right?
You are unmuted.
Okay.
The floor is
Sorry
yours.
about that. So yes, my point, thanks everyone, is about the Michael Flanders Centre. And I'm concerned that it's being sold off and is earmarked for sale. I think there's intensive housing in the Acton Gardens development, and obviously that population will age, and it's very short-sighted to get rid of an old person's, and dementia and Alzheimer's are on the rise, to get rid of a council-owned provision for that group in terms of health and well-being, with the levels of housing that the Labour Council is endeavouring to deliver. I know that there were 6 Ealing Council-owned adult social care homes, and now there are 2. I've looked at the consultation and I find it a bit of a non sequitur and rather sort of bogus, really, because you've said that you're moving provisions from Michael Flanders into Sycamore because of journey times. But actually, if you look at the consultation, 50% of the users live a stone's throw from Michael Flanders, and there's no reason to sell that building at all. That can still operate as the venue that serves those patients, those users that live in, those residents that live a stone's throw from Michael Flanders, and still go ahead with serving Greenford with the Elm Lodge. I don't know if it's been done. It says that you said you've not done it for cost cutting, but it looks to me quite clearly like you're trying to plug some sort of deficit in the adult social care budget by selling that off to the Acton Gardens developers. And I don't think that that is what residents want. I think for it to remain in the hands of the local council is really important as a as a legacy for the, you know, for the, not only for people to use now, but for those to come, generations to come. And there's a loneliness epidemic. There's a lovely garden there. People can wander around in a secure way because the garden's protected. It used to be a hub for help. Was it Help the Aged or Age UK? I know that drug and alcohol groups used to use the building, which is very important for addressing sort of addiction and stuff like that. There was Acton High School, who used to give lessons to the elderly and how to use technology. Again, a very, very important thing. And I think politically it's going to be very, very unpopular. I think Labour should advocate.
So sorry, can I?
people.
I'm really sorry. This is not. This is a meeting of the Health and Wellbeing Board, which is the governance and assurance of the health service and adult social care. It is not a forum for certainly either myself or anyone else to use as a political forum. We had extensive consultation and public meetings. We had, I believe, cabinet reports, and certainly it was raised at full council as well. There have been. I'd be very happy to meet you.
Building? What are you going to do with the building?
I'm going to pass over to, and I would also, I'm not going to get into this debate now.
I mean, I've read the consultation, and what I've said is
again, this is a forum where we will be expecting to hear from
residents that use that service live 10 minutes away from it, so there's no need to sell it.
There is a causal impact there. I mean, have you ever been in the building?
Yes, many times. And I've also looked at your children's centre consultation, which is now in the High Court.
So this is not the forum for a political.
It's not political.
Debate.
It's about how you deliver services for health and well-being, and you're selling another.
I will pass over to Kerry Stevens, who is the Director of Adult Social Care, who will respond.
Thank you, Chair. Thank you for the question. Just to be clear, in terms of the consultation document, sets out very clearly that this isn't a reduction of services. This is not getting rid of day services, as the questioner has put forward, but we're expanding our day service offer in the borough, expanding essentially from 2 sites to 4 sites across the borough to reduce travel times for individuals coming into services. Sycamore Lodge is within 100 yards of the Michael Flanders Centre, so it will still service the community in Acton and surrounding areas extraordinarily well. The secondary site at, or not the secondary, the second site at Elm Lodge will be much more accessible to people using services in the west of the borough. So I think
so you've repeated what you said in the consultation, which is fantastic. I'm really glad.
Excuse me,
I cannot have you talking over officers.
You were saying that 50% of people live within the local area of Michael Flanders site.
They do.
We're still going to have a service within 100 yards of Michael Flanders site. Excuse me, do you mind not cutting across me? Can somebody mute the caller when I'm speaking, if that's okay? The secondary site will be based at Elm Lodge, which is further to the west of the borough, reducing travel and distance for users of the service in the west of the borough. Sometimes who can spend up to an hour and a half on the bus going to and from the site. So I don't think that the point raised is relevant there. There are no cost-cutting aims within this piece of work from an adult social care perspective. This is about making our services more locally available, more accessible to the community, and more reflective of the needs of the community rather than all being provided from a single site. So there's no reductions in spend from an adult social care perspective. If anything, Chair, we're looking to expand and grow the people attending the service to reflect the increase of people in the community with dementia type illnesses, and therefore expanding the capacity should draw more people into service, which we think will be a huge benefit for the community of Ealing going forward. as you said, Chair, this is an officer-driven piece of work that's been presented to members through formal processes in the council process. There are no political actions from officers within Ealing Council. We see this as hugely to the benefit of the local community, expansion of services more reflective of the needs of the local communities, and significantly reducing travel times for local residents. Thank you.
Okay, thank you very much for questions from members of the public. That brings us to the end of the meeting, but what I would like to do is have a brief discussion around where we are as a health and wellbeing board, and we've had many discussions collectively around the role of the health and wellbeing board, the changing NHS landscape, and the broader assurance and governance issue around the interaction between the integrator and the health and wellbeing board, and what that looks like for us all. I feel like we're somewhat stalled, and it feels like we need a clear and sort of strategic oversight of the operational direction of that transition, and we need to be very clear about what the role of the board will be going forward around governance and assurance, and what the operational remit will be. I appreciate there are some unknowns in the as we stand, but I'm equally will reiterate that this is our opportunity within Ealing to grab some of this stuff and make it work for us. We don't need to wait until everything is in place with nationally or regionally. In fact, I'm reasonably confident it will never be in place in terms of being a finished piece of work. So I think we have real opportunity to exercise that agency locally, and I suppose I'm concerned about where those discussions are happening. So I'm sure they are happening, but they're not happening at this level, and so would make a plea to partners, stakeholders, our integrator, and ourselves, that we really start building that partnership at pace, because how it's going to work, how it's going to operate, and what it's going to mean in terms of priority assurance governance is less clear. I appreciate everyone's working within a stressful backdrop, but I am and hope I have always been clear that the Health and Wellbeing Board is not a place where we expect to bring reports and listen to them and ratify them. It is where we set the priorities and drive the collective vision that we have for our residents. So people are very welcome to comment, but I do think we can be braver and bolder and perhaps even less complex in this space than we expect. But I do think we need a very fully fleshed out update, certainly by the next time we meet. But we need to think forcefully and carefully about who is in the room, what our expectations of them are, who isn't in the room, and what we expect of them, and to bring some of that transparency and openness to the discussion about what we do around the big things, like what do we mean and what are we going to do about neighbourhoods, what do we mean and what are we going to do about prevention, and how are we going to really work together to sort of solve those big issues, because I think we do have a significant opportunity to really change the dial on some of those things, and we can only do it by working together. So any thoughts and comments and input? Kerry.
Thank you, Chair. I think there is, and there may be an issue with some of us have been here for a long time and leaving shortly. So I think there's a huge opportunity to come at some of the interfaces and the work programs with a fresh pair of eyes in the nicest possible. I'm not including you in the same way, obviously. But I think there's real opportunity. I think Adenike Tilleray will bring a fresh view and fresh engagement to the Director of Adult Social Care and Lead for Public Health with Anna in Ealing. I think that shift is going to be very beneficial to the system. My parting view on the integrator is we need to get the clarity around how the engagement works, as you say, to set what the business arrangements and the working relationships are, and then set very clear positions on what we're looking at. I think as we were talking earlier with David with regard to simple things, how do we do engagement with the community as a single Ealing integrated approach is a real opportunity. There's a huge amount of duplication in the health and social care system from the West London Trust have a rehabilitation team, and we have a reablement team to do very similar functions within the community. And as a system, I think we need to be bringing to you and the Health and Wellbeing Board options how to drive that integration more closely. And I think the commercials are going to be really important in terms of understanding how our finances are dealt with and where we're all sat in terms of our modelling of monies going forward. The opportunity is some of the early discussions around left shift of money from the acute into the community. And if we're not prepared for that as a system, there's going to be a huge loss of opportunity to support, Ealing communities benefit from the 10-year plan and the shift into integrated models. I don't think we've been doing enough in terms of informing you and the Health and Wellbeing Board of the good works that are being done. There's some really exciting work being done around integrated teams around frailty pathways, which are looking really beneficial at a very early stage, but we need to bring that here for discussion so that we can build on those opportunities going forward. I think it's going to be really exciting, and I'm sorry to be missing it, but I think there's going to be a really exciting time to bring systems together.
It's great, Kerry. Thank you. Neha, would you like to share your thoughts?
Yeah, thank you very much. So we're in, as you say, an unusual time. We've got a lot of changes happening to the ICB as well, and rather than having a local footprint from the ICB perspective, there will be a North West London wide team who will have to reach into the 13 boroughs that the new ICB will work and interface with. But I think Kerry is right. I think the strength is our local partnership, and we have built into our governance as a borough-based partnership already that our borough-based our partnership, actually the formal reporting is into the Health and Wellbeing Board. And I know we don't want to receive papers here and just talk about papers, but actually sometimes receiving the right papers can generate interesting conversations and the right conversations about the future strategic direction. We're doing work on, as Kerry has described, around a fantastic frailty pilot that we've done without any additional funding, but just changing the way we all work together in an integrated, much more integrated lens. We're doing similar with children's and our child health hubs with 5 out of 8 mobilised. We need to be talking about our footprints that we operate at, because the council has the 7 towns plan, and neighbourhoods, because of the population sizes, we've agreed to operate neighbourhoods at the primary care network level. There's great work happening on inequalities. There's great work happening on supporting the hospital cope at, pressured times, but also throughout the year, and keeping our residents at home where they feel safe and supported, but with the right care around them. The integrator stepping into this space with West London NHS Trust really starting to step into this space that the Place Borough team has had from the ICB is going to be an interesting shift, because in one way, as a West London Trust, they're a local provider in the local system, but they're going to have some sort of independent team that is supporting all of the partners and listening to the voice of the partners. And I think the Health and Wellbeing Board, through the Health and Wellbeing strategy, can really give some direction about what we're all trying to achieve over a period of time, and which I think we've done some great work with, but we could do much more in that. So I think receiving papers sometimes can help generate some of those conversations that we aren't having at the moment, I think. And we're in the process of trying to put together a summary of all the work that the Borough-Based Partnership is currently doing in a digestible way.
Thank you, Neha. Is there any, as the sort of, I suppose, the representative of the, it would be good to get your perspective, and then I'll go to Mark, who's online.
Yep. Thank you, Chair. So I'm Lizzie Bovell. I'm the Director of Transformation for West London Trust here on behalf of Dr. Hilton. I agree with everything that Kerry and Neha have said. I mean, Ealing is in a strong position at the moment. The partnership has been developed over a number of years. We've got good and positive relationships within the patch, and also already between the integrator and the Health and Wellbeing Board. I do think that we're in a transition point where we're losing the resource and support of the ICB and all of the project management support that's gone before. And it's a transition point, losing Kerry as well, for us all to think about what does that mean in terms of how do we reprioritise, because we won't be able to continue at the scale of change that we have had with less resource. So how do we prioritise the resource that we have got, and how do we move forwards with that? I think there is we've discussed today a number of questions about Health Watch and about patient engagement and public engagement in the process, and I think that is a question that we need to continue to ask as we move forwards. How are we all doing that engagement? How do we avoid that duplication, as Kerry has said, and try and ensure that the voice is being heard? But there is also, and we can't shy away from, the financial pressures of the future over the next 3 to 5 years, and how are we going to create more efficiency in our services, and that's going to involve staff as well. So we need to include staff in this conversation around those staff changes, and working in very different ways perhaps than they have done previously, within their professional capability, but in partnership with others, to be able to create those services around the needs of our neighbourhoods and our local residents. So West London, as Neha said, is in that conversation at the moment, both from a provider perspective, but also as the integrator for the system, and is actively in discussion and would happily have conversations with other members of the board outside of this around how we create the right structures going forwards. And perhaps we can revisit this at the next meeting of this group after the elections.
Thank you very much, Lizzie. Agreed. I mean, we are in transition, but we also need to understand what our local levers are, how and where is the money going to flow, and to whom, where are opportunities further down the line for building models, for if we are going to avoid duplication and look at things that we can do together. How do we do that at a system level around what mechanisms we already have to do that, and where can we be sharing budgets and also establishing priorities. Financial pressures we know well, and they can lead to innovation. Would that be fair? And they can certainly lead to thinking in a more preventative way about what you do. So I would just urge that partnership, and we do need to start seeing. We know that there are many demands on and different perspectives within, and all of whom have their own levers and own ways of drawing funds away from or prioritising. So I think we just want to move to having a collective sense of how we do that work. Mark, I'm going to come to you before Kerry, and then Robert.
Thank you, Chair. Yeah, I think quite a lot has already been said around the transition point, and that's been well articulated. But I guess that gives us both a bit of a threat, but it also gives us a real opportunity in terms of that transition piece. I think from a hospital perspective, from an acute perspective, we are doing a lot of work on this, not surprisingly, particularly with the shifts around the prevention agenda, which has been mentioned already. We see ourselves at London North and West very much as a key partner alongside West London as the integrator in developing the thinking and the planning as we move forward. And I understand that you want to see some of that flow through to Health and Wellbeing Board, but I'd want to reassure that that work is certainly going on, and within the hospital we're giving that a lot of thought. We think there's real opportunity in Ealing in particular, and from a hospital perspective, we really recognise that we've got some critical enablers in this area. So we've got our hospice, we've got our community diagnostic centre, we've got our urgent treatment centre, we've got a number of other community services which we think places Ealing Hospital as part of that partnership with the integrator and as part of the community in a really, really unique position. And so for us, it's how we can build on those opportunities that some of those that I've mentioned already, and actually then take that forward in terms of some of the plans that we want to develop around the partnership and around the integration role. And we're beginning to articulate that with our colleagues, some of those at the meeting today, and we're also developing that as very much a key strand of our thinking here at London North West, and we're doing that in Ealing in the same way that we're doing it in the other boroughs which we serve from our other hospitals. So I hope that provides an element of reassurance for you, Chair.
Yeah, I'm sure the work is happening. I just want to make sure it's all joined up and that we have due oversight. Kerry, did you want to come in?
Thank you, Chair. This may seem a bit strange to say, but I think the financial challenges being felt across the system are going to drive us more closely together, to work more closely together. I think the shift in terms of expectations that NHS trusts have been expected to achieve in terms of their budget setting and budget spend is a very different position from what we've experienced in previous years. And I think that brings us all closer together and around the table to have a better understanding of how we maximise the impacts on all of the systems. So what we do in the community, how it impacts on colleagues in the community trust, and then how it impacts on admissions into hospital. It becomes a lot more real as a system, and it forces us to work together more effectively in that space. And I think it's really important that we have the openness of our financial positions within that space. I think as well, to add to Mark's point, we're in a very strong position. Over the 7 years I've been in Ealing, I've had all sorts of fights and arguments with colleagues at the trust in terms of discharges, but performance at the moment is probably as good as it's ever been in Ealing. I think that's puts us in a really strong position to keep those partnerships operationally in a strong place, so that we can do this work together without getting distracted by sort of arguments about process, arguments about flow, which distract us from the bigger issues. So I think it's a very strong time for us to go forward.
Great. Robert?
Thank you, Chair. I mean, first of all, I suppose I just want to put on the record my thanks to colleagues across the ICB for their work, certainly since I've been here over the last 3 years. Particularly Nehar, because I think we have seen a significant shift, and we've produced some really excellent outcomes, certainly in the children's space. We had developed some pretty extensive plans in this space. And with the changes, what we've been doing recently is, in fact, we had another meeting yesterday, is just meeting to try to hone in on what we think is most important during the period of transition. And actually, we are honing in on that prevention piece, but also trying to develop our plans in a way that decrease duplication and identify opportunities for greater integration and cooperation. So I think that will be something, that piece of work will be something that we can bring here to an upcoming board, certainly following the election. In that space, though, I think it is really important, and this is why I mentioned the work that Nehar has been leading on, and we've been working on as a collective. I think the relationships are fundamental. They very much matter in this space, and so I think the ongoing work of the board in terms of some of the work which you've been sponsoring around the board development and how we work as a board outside of these formal meetings, I think is also really important in that space as well. And I think there's some really great opportunities there. Outside of the integration agenda and prevention, I think the other key issues for us going forward is really around some of these core statutory functions, particularly with regards to the special educational needs and inclusion agenda, which we know is going to require a generational shift in the upcoming period, continuing healthcare for our children, young people, and vulnerable adults. I think that's a really important area. And although it's not the direct responsibility of this particular board, but it is related to other boards, both in the adult sphere and also children's, having an eye on safeguarding as well, and the connectors and the links to wellbeing. I think those are really important areas that the board satisfies itself are being discharged appropriately as this transitional period takes effect. And I think linked to those areas, we'll need to ensure that we are learning from what is happening across the 13 boroughs, learning and also sharing our experiences so that we get the best from the region, and also related developments elsewhere.
It's great. Thank you, Robert. Thank you for your comments and that child focused perspective. It's very helpful. Over to Anna.
Thank you, Chair. I think for me, it was just finishing off with that. We've been talking about over the last few weeks about the health and wellbeing strategy and the ways of working in the board that we've been working on the last couple of years. I think it's shoved us forward a long way in the last couple of years in terms of prioritising what we think we need to work on together and how important that is. I think I'm just thinking forward to the June meeting of this board. A lot of organisations and individuals shift, and us as a board really holding on to that as our heart. I think there are risks that going forward, any of the national guidance potentially narrows the focus of boards, and I think there is something for us in Ealing really holding on to the heart of what we've been doing, that great work that really focuses on kind of working together in terms of preventing poor health, massively reducing the inequalities as well. I think are two aspects of this that some boards don't necessarily look at, rather than kind of just the oversight of the kind of health and care system, which is massively important as well. But I think there was something for us over that next 6 months with all this change around us, really holding on to what we're trying to do as a board and not letting go of that. Thank you.
Yeah, it's a very good point. There is lots of change, and we are unfortunately seeing greater inequalities, not less, and greater deprivation in Ealing. So these will obviously all impact on health, both physical and mental, now and in the future. On that cheery note, I'd like to bring the formal part of the meeting to a close, but it is the last meeting. Hopefully not of all of us, but I would like to firstly say thank you so much to Kerry Stevens, our Director of Adult Services, and is given 7 years to Ealing and has been a hugely respected and liked colleague and part of the Ealing scene. Certainly talking to all of our staff, they are very sad to see you leaving, and you've definitely brought your very unique and knowledgeable way of working, and I, on a personal note, hugely appreciate and value and thank you for everything that you've done to support me on this journey of coming into adult social care and public health, not really knowing a great deal about it, but hopefully now able to feel confident that we can work on improving the outcomes for our residents. So thank you, Kerry. Enjoy whatever you do next. I think it's and really thank you so much for everything you've done for all of us. We will miss you hugely. And secondly, goodbye to Nehar as well, who is leaving us in April. And thank you so much for everything you've done for the people of Ealing. You know, your compassion and commitment to us as part of the system, as colleagues, but to our residents has shone through in everything that you've done from the first time I met you. And I know that you are a hugely valued part of our strange little ecosystem, and a huge reason why, when we talk about the strong relationships and the partnerships and the work that we do in Ealing, why all of that is so strong. So thank you so much. I'm sure whatever you go on to next, you will be equally as brilliant, but I hope that the very first thing you do is have some time off and enjoy yourself. And we really thank you for everything that you've done. So thank you to Nehar. And it would also worth noting that Adenike, who many of you will know, will be stepping into the interim Director of Adult Services and role in, I suppose, from next week, from next Wednesday, next Thursday. And she is enormously brilliant and accomplished. And I think, although we'll miss you, Kerry, we know that Nike brings a very, alongside her sort of compassion and passion for Ealing, a very structured and forensic way of working that I think will serve us all exceptionally well at this time when we're trying to pin down priorities and ways of working and governance and all those sorts of things. So I very much look forward to her being at the next meeting. And on that note, apparently there's an election coming, so I may be here as as your chair of Health and Wellbeing Board in June. I very much hope so. But if I'm not, thank you all for all the support and help that you've given me, and I'll draw the meeting to a close. Thank you, everyone.